welcome Dr. Onida. She's a registrar in Division of Dermatology with a keen interest in infectious diseases. And today she's going to present to us the deep fungal infections of the skin.
Morning, everyone. My name is Dr. Venter, and I'll do deep fungal infections with you guys today. Sorry for starting a little bit late. And I've tried to focus this talk on medical students in the audience, as well as interns, as well as registrars, so that everyone hopefully learns something today. And I really hope that you are here for me and not just for the freebies at the back. I'll be starting off this talk with a brief overview of cutaneous fungal infections, whereafter we will delve deeper into some cases that we've encountered in our clinic. Okay. Cutaneous fungal infections are broadly divided into two groups. First of all, you get the superficial mycoses due to fungi that only invade fully keratinized tissue, namely your stratum corneum, hair, and nails. These are known as the dermatophytes. And then fungal infections that involve the dermis and subcutaneous tissue or deeper tissue. Deep cutaneous mycoses are often the result from direct inoculation, or they may represent systemic mycosis with cutaneous findings. Systemic mycoses are usually acquired through the respiratory system, and they can subsequently spread to all organ systems. Today, we will delve deeper into the deep fungal infections. Ooh. Subcutaneous mycotic infections are caused by a heterogeneous group of fungi, and they are infections of implantation, meaning they are inoculated directly into the skin through local trauma. The four most common infections are sporotrichosis, chromoblastomycosis, phaeohyphomycosis, and mycetoma. As a group, these infections primarily involve the skin and subcutis, and they rarely disseminate in the immune-competent host. These organisms are ubiquitous in soil, plants, and trees. Systemic mycoses with cutaneous features are caused by opportunistic as well as true fungal pathogens. Those due to true pathogens include histoplasmosis and blastomycosis, amongst others, and they are caused by dimorphic fungi. What do I mean by dimorphic fungi? It means that the fungus can exist in two forms, essentially as a mold in nature and as a yeast in living tissue. All right, this brings me to the fun stuff, our case studies. So our first case is that of a 32-year-old female patient. She's RVD negative and known to rheumatology with inflammatory arthritis. She presented with a long-standing history of slow-growing lesions to both hands, now progressing proximally to involve the right volar wrist. On careful cutaneous examination, one can appreciate the verrucous nodules to the dorsal aspects of the index and pinky fingers overlying the PIP joints. The right volar wrist has an ulcerated plaque with a surrounding rim of hyperpigmentation, as you can appreciate in the picture. Multiple biopsies were taken for H&E and culture, and we considered a few differentials. Is there any thoughts from the audience? Or am I just going? Okay. Our differentials mainly focused on infective etiology, and different fungal as well as bacterial causes were considered. Ultimately, a diagnosis of sporotrichosis was made, and this was supported by histology and special stains. So what is sporotrichosis? Sporotrichosis is the most common of your subcutaneous mycoses, and it's caused by the dimorphic organisms of the genus Sporothrix. A gardener being pricked by a contaminated rose thorn is the classic vignette for acquiring sporotrichosis, and it's often referred to as rose gardener's disease. Although sporotrichosis has a worldwide distribution, it is more frequent in tropical and subtropical climates. Exposure to the organism typically occurs in those working outdoors, such as gardeners, florists, people working with vegetation, such as wood, plants, and flowers. And it can affect all age group, but they do note a slight male predominance. All right, the initial presentation of sporotrichosis is a single papule at a site of injury, most commonly affecting the hand, and it occurs several weeks after inoculation. This may be followed by an erosion or ulceration with purulent discharge, and it's generally not painful. Three types of reactions can be described: your lymphocutaneous pattern, localized or fixed cutaneous pattern, and disseminated. In the most common form, the lymphocutaneous form of sporotrichosis, lesions develop at the site of inoculation, most often to the exposed area, after an incubation period, and then later forms a nodule that ulcerates. Lymphatic involvement with asymptomatic secondary nodules arising along the line of lymphatic drainage then develops. Regional lymph nodes can become enlarged. Meanwhile, your initial or primary lesion will expand as a crusted plaque. In the localized or fixed form of sporotrichosis, the patient can present with pyodermatous erosions, acneiform, nodular, ulcerated, or verrucous lesions. This variant may indicate a high degree of immunity in the individual. The pattern of spread of fixed cutaneous sporotrichosis can be appreciated in our patient. Disseminated sporotrichosis is very rare. There has, however, been a number of patients reported with disseminated sporotrichosis in the immune-compromised population. Always remember that sporotrichosis can also be an uncommon cutaneous manifestation of iris in a patient that has received ART. Let's just get the slides to go. Right. Clinical suspicion is essential for diagnosis. A detailed history regarding travel, occupation, hobbies is important. The gold standard for the diagnosis is the isolation of this fungus in Subarot dextrose agar. The colony is characterized by radiated growth and the characteristic microscopic features of Sympodial conidia representing daisy flowers, as you can see in the picture on the slide. Tissue staining with PAS and Grocket may also enable visualization of the yeast. Intradermal skin testing can also be carried out with sporotrichin antigen. It is considered to be positive when erythema and induration appear at the injection site after 48 hours. You perform this the same that you would perform a PPD test. A positive reaction supports the diagnosis of sporotrichosis, but it's not definitive because asymptomatic individuals in hyperendemic areas may be sensitized. Another limiting factor, obviously, is that it's not available in our setting, but the one major advantage of the sporotrichin antigen test is that it expedites your definitive diagnosis. Serology to detect antibody titers can also be done, but low sensitivity and cross-reactions makes this test not so reliable. Sporotrichosis generally follows a benign course with a good response to treatment, and reports of spontaneous healing has been reported in the literature. Itraconazole works well for cutaneous sporotrichosis, and it remains the treatment of choice for lymphocutaneous as well as fixed cutaneous sporo. Amphotericin B may be indicated in severe or disseminated disease, followed by long-term itraconazole in immune-suppressed patients. Historically, sporotrichosis treatment was based on the application of a saturated potassium iodide solution, and it's still used in developing countries due to its low cost, but its efficacy remains variable. I've included this slide mostly for the med-regs. Many conditions can follow a sporotrichoid or lymphocutaneous pattern of spread. And on the slide, I've included the list to take into account when you see a patient with a sporotrichoid spread. The mnemonic of cat and splat alludes to the following conditions: cat scratch disease caused by Bartonella hensley, atypical mycobacteria, tuberculosis, nocardia, sporotrichosis, few hypomycosis, leishmaniasis, anthrax, and tularemia. Right, this brings me to the second case. This is the case of a 42-year-old male patient that presented to our clinic with a 3-year history of swelling to his right foot and areas of draining. Over time, it was gradually increasing in size with mild discomfort. No pain was experienced upon weight bearing. Patient has no chronic illnesses and his RVD status is negative. On examination, a firm mass localized to the right forefoot extending to the level of the midfoot is present. Destruction of normal foot contour and obvious deformity with minimal pain on palpation. Multiple draining sinuses with seropurulent discharge and areas of surrounding crust can be appreciated. And then of note, no grains were visualized on clinical examination. The lesion is also enveloping the 4th and 5th phalanges with partial submersion of the 2nd and 3rd phalanges. You can also appreciate the presence of draining sinuses to the plantar aspect of the foot. The rest of the systemic examination was unremarkable. Our differentials included the following diagnoses: mycetoma, botryoomycosis, chromoblastomycosis, although the morphology is not in keeping, and osteosarcoma, although the duration makes this clearly unlikely. Our workup included a skin sponge biopsy for H&E and tissue for culture, as well as an X-ray to assess the extent of tissue involvement. In the slide on the left, I know this is a lot of histology and yeah, even I can't make sense of it yet. In the slide on the left, a lymphoplasmacytic infiltrate within the dermis is seen, suggestive of chronic inflammation. On a higher power, when you move to the middle slide, you can appreciate basophilic clusters representing aggregates of microorganisms surrounded by a pink eosinophilic rim. This is known as the Splendor-Hopley phenomenon. Splendor-Hopley phenomenon is a distinctive reaction characterized by radiating amorphous eosinophilic material surrounding these colonies of microorganisms. This pink staining material is composed of antigen-antibody complexes, fibrin, and degenerated inflammatory cells. You may be thinking, why did I include this in a medicine talk? But I've included it because it's a really remarkable histology, and you'll never see it as beautifully as you've seen it in this slide today. So this is an X-ray of the right foot depicting bony involvement. There's an expansile lobulated density of the forefoot with destruction of the 2nd to 5th metatarsals and their phalanges, remodeling of the metatarsal cortices and metatarsal heads, as well as disuse osteopenia, indicates this chronic process. This brings me to a discussion on mycetoma. So mycetoma is a chronic granulomatous infection of the skin and subcutaneous tissue, and it's divided into two separate categories, where infections caused by fungi are classified as eumycetomas, and those with bacterial etiology, actinomycetomas. In 2016, the World Health Organization included mycetomas on their list of neglected tropical diseases. Mycetomas are endemic in tropical and subtropical areas, and the majority of cases are concentrated in, but not limited to, the mycetoma belt. Worldwide, about 60% of mycetoma cases are bacterial in nature. However, on the African continent, eumycetomas are more frequently observed. This disease predominates in individuals who have regular and direct contact with field environments, such as laborers, herdsmen, and farmers, commonly affecting ages between 20 to 40 years of age, and males being affected more likely than females. The causative organisms are acquired from the soil via direct inoculation into the skin, leading to a dermal and subcutaneous fungal infection. Obviously, deeper invasion to muscle or bone can subsequently occur, and this process may occur rapidly, such as the case of actinomycetomas, or over many years, such as seen in eumycetomas. Lack of protective footwear, malnutrition, and exposed cuts and abrasions are risk factors for acquiring the disease. Inoculation is followed by the development of a painless subcutaneous nodule that eventually evolves, and the characteristic triad of tumification, draining sinuses, and discharging grains becomes evident. Actinomycetes exhibit a more rapid clinical course with increased inflammation, local destruction, and bone invasion compared to their eumycetoma counterpart, as fungi tend to stay encapsulated for longer periods of time. Typically, it demonstrates unilateral involvement, with the foot being the most common site of infection in around 80% of cases, and then followed by the hands and the knee joint. Remarkably, even with extensive disease, neither pain nor systemic manifestations are usually present. Of note, discharging grains may sometimes be visible to the naked eye, and they may provide valuable clinical clues as to the offending organism. They represent microcolonies of the causative organism within tissue, and you need to note the size, the form, and their color. I know this is a busy slide. I've just included it because it depicts the different colors of grains found in eumycotic and actinomycotic mycetomas respectively. Laboratory investigations to follow after you've now either done a tissue, a biopsy, or even you've seen a grain, or you've aspirated a grain from the sinus, include PCR to help identify the causative organism. However, definitive diagnosis is established by isolating the causative organism, but culture positivity has only been reported in around 50% of cases. As exact identification remains a difficult and daunting task for dermatologists and pathologists alike. This table depicts the various factors contributing to the low percentage of culture positivity in mycotomas, and this really reflects in our setting. This resonates in our setting. Management of mycotomas are directed towards the specific causative organisms, and the treatment of eumycotomas, which are caused by true fungi, remain a therapeutic challenge, often requiring a multidisciplinary team. Eumycotomas are treated with a combination of antifungal agents and surgical procedures. Most frequently, itraconazole is used, and usually the antifungal treatment is given for months and sometimes even years. Itraconazole remains the gold standard. The usual dosage of itraconazole in eumycotomas are 400 milligrams per day. You divide them into 2 dosages, 200 morning and 200 in the evening. And then just as a side note, remember to monitor the liver function at baseline and throughout therapy. Other antifungal agents that have been deployed in the medical management of eumycotomas include ketoconazole at 400 to 800 milligrams per day, as well as high doses of terbinafine at 1,000 milligrams passed daily. Surgery is often also performed as first-line treatment for eumycotomas, and care must be taken throughout the surgical procedure to prevent contamination and further infection. So they place emphasis on maintaining the integrity of the capsule. Aggressive wide excision should be performed in local lesions, and debulking surgery reserved for extensive disease with bone involvement. As a take-home message on mycotomas, I also included this table depicting the clinical differences between eumycotomas and actinomycotomas. To distinguish clinically between a eumycotic and actinomycotic mycotoma is really difficult, and it's important that every possible clinical clue needs to be extracted from the history and examination. Treatment of these two conditions are worlds apart, with a long therapeutic journey for the patient ahead, and we need to be certain on the pathogen before we endeavor on this healing journey. This brings me to the last case. Our third case is that of a 34-year-old male patient with a background of retroviral disease and a CD4 count of 2. The patient was admitted with a productive cough and constitutional symptoms, and he also reported a 3-month history of these pruritic skin lesions. Of note, he's previously treated for MDR-TB. On cutaneous examination, erythematous to pink plaques with a violaceous rim is present, sparing the nasolabial folds. One can also appreciate the violaceous plaques to the forehead, upper lip, anterior chest, with slight atrophic pink centers. Other photo-distributed areas involve the hands and forearms, where lesions of a similar morphology can be appreciated. Systemic examination revealed a hepatomegaly, and on laboratory investigations, a marked bicytopenia was present. Do we have enough differentials is the question. So our differentials included mainly infective causes, although we also considered seborrheic dermatitis and lupus erythematosus. Multiple skin biopsies were taken for H&E as well as culture. This brings me to histoplasmosis. So, histoplasmosis is caused by the dimorphic fungus Histoplasma capsulatum. Particularly high endemicity occurs in the river valleys of the US, Latin America, and tropical Africa. Historically, an African clade of histoplasmosis, namely Histoplasma duboisi, has been described, where patients primarily present with cutaneous manifestations without pulmonary involvement. Furthermore, these patients were usually not immune compromised. Environmental factors such as moderate temperature and bird or bat guano-containing soil are highly associated with the prevalence of organisms, and activities that disturb this microfoci are a risk factor for contracting the disease. These activities include things like farming, exposure to chicken coops, caves, renovation of old buildings, clearing of trees and brush from roosting sites. Histoplasmosis is caused by the inhalation of Histoplasma capsulatum, but rarely also through the direct cutaneous inoculation of the fungus. The vast majority of infections are subclinical and self-limiting due to our adaptive cell-mediated immunities. Rather, host factors, such as severe immune compromise, lead to symptomatic infection. The clinical presentation of histoplasmosis can include pulmonary histoplasmosis, disseminated histoplasmosis, and primary cutaneous histoplasmosis. In disseminated histoplasmosis, the most common sites of involvement after the lung are the spleen, the lymph nodes, the bone marrow, and the liver. Cutaneous manifestations are most commonly the result of disseminated disease. The skin lesions of histoplasmosis are nonspecific, making the diagnosis virtually impossible with physical examination alone. Mucosal ulcerations is a common finding in disseminated histoplasmosis, and cutaneous lesions typically involve the face, the trunk, and the extremities, with lesions having a wide range of morphologies, as we've mentioned. Plaques, nodules, umbilicated papules, acneiform eruptions, pustules, and even paniculitis. Can be anything really. Histoplasmosis can be diagnosed by direct microscopy, culture, serology, or antigen testing. Direct visualization with GMSA staining of the yeast on tissue or blood is a rapid and cost-effective diagnostic test, but it has a low sensitivity. Culture of the fungus is the gold standard of the diagnosis, but it may also take up to 6 weeks to incubate. Histologic examination is recommended for all cases of cutaneous histoplasmosis. However, sensitivity is also low. Granulomas with or without caseation, lymphohistiocytic infiltrates, or monocytic infiltrates are typical. Serologic testing is also available, but it's not really useful until 8 weeks after exposure, and it may be positive for years. Histoplasma antigen can be measured from the urine, from the CSF, from bronchoalveolar lavage specimens, and even within 24 to 48 hours. With urines having a urine sensitivity of more than 90% in patients with disseminated disease, and a urine sensitivity of about 80% of patients with pulmonary disease. The antigen level predictably decreases with treatment, and you can use this antigen levels as a means of monitoring relapse in your patients. Right. In asymptomatic histoplasmosis, treatment may not be necessary. In the immune-competent host with mild to moderate stable disease, itraconazole 200 to 400 milligrams per day remains the treatment of choice. However, in symptomatic or disseminated disease, systemic antifungal therapy with amphotericin B is required. It's given intravenously at a dose of up to 1 milligrams per kilograms per day, and this is followed by maintenance itraconazole. HIV-infected patients with disseminated histoplasmosis will require lifelong maintenance therapy after their initial treatment with amphotericin B. And I really try to keep it short and sweet. This brings me to the conclusion. Right. To conclude today's talk, I want to leave you with the following. Deep fungal infections of the skin may cause life-threatening illness, but it also more often leads to significant morbidity. It's important to recognize these lesions and diagnose them accurately so that the appropriate antifungal therapy can be initiated. Remember, in a setting where HIV remains highly prevalent, the patients that we encounter are particularly susceptible to falling victim of systemic mycotic infections, and by enhancing our awareness and clinical vigilance, we can reduce this burden of these challenging infections. To further exacerbate matters, we are living in a time where climate change is very real, and it's impacting the world around us, affecting all of the ecosystems. Persistently warmer temperatures allows for fungal species to advance into new territories, and it also gives them the capacity to develop thermotolerance, meaning they survive for longer times in heat. More frequent extreme weather events like heat waves, droughts, flooding also foster circumstances that favor the survival of the infectivity of pathogens. So I hope that you've learned something from the talk today and that you can recognize if something is a possible deep fungal infection and manage or at least refer appropriately. Thank you. Is there any questions?